Hi, good afternoon, everybody. My name is Luvia Quiñones. Welcome to today's webinar, an overview of the Affordable Care Act, its implementation in Illinois, and its effect on immigrants. Our panelists for today will be myself, Luvia Quiñones from ICIRR, Kathy Chan from Illinois Maternal and Child Health Coalition, and Andrea Kovac from the Sargent Shriver National Center on Poverty Law. A bit of an overview of ICIRR, the Illinois Coalition for Immigrant and Refugee Rights. ICIRR is dedicated to promoting the rights of immigrants and refugees to full and equal participation in the civic, cultural, social, and political life of our diverse society. More information, you can visit our website, icirr.org. Now Kathy's going to tell us a little bit about her organization.
Thanks, Livia, and thanks to ICIRR and Shriver Center for inviting us to be part of this webinar today. My name is Kathy Chan, and I'm with the Illinois Maternal and Child Health Coalition. And for those of you who aren't familiar with the work that we do, we're a statewide organization that works to promote the health and well-being of women, children, and families throughout Illinois. On this slide, you'll see a list of our different projects that we run. We hope that you will be encouraged to get involved with our projects. Our website is on here as well, and we are active on social media. So if you'd like more information about the work that we do, please do feel free to get in touch or visit one of our websites or social media outlets. And now I'm going to turn it over to Andrea.
Hi, everybody. The Shriver Center provides national leadership in advancing laws and policies that secure justice to improve the lives and opportunities of people living in poverty. And we regularly advocate to ensure that all people have timely access to comprehensive, quality, affordable health care. We also regularly provide presentations on the Affordable Care Act. Now I'm going to turn it back to Luvia to provide an overview of today's webinar.
Today's webinar will provide an overview of the Affordable Care Act, or known as the ACA, including some of the most important reforms to the insurance market, an overview of the new health insurance exchange marketplace, and the ACA's changes to the Medicaid program. Once you have a general understanding of the ACA, our panelists will spend some time looking at how immigrant populations will benefit from the ACA, as well as areas for improvement to ensure health insurance is available to everyone. Next, our panelists will present some advocacy opportunities for you all to get involved in. Then we will provide additional resources and answer your questions. Please use the chat feature to ask questions throughout the webinar. You do not need to wait until the end in order to ask questions. Now I'll turn it over to Andrea to start us off by presenting some of the ACA's insurance market reforms.
Thank you, Luvia. So on March 23rd, 2010, which seems like a very long time ago, President Obama signed the Patient Protection and Affordable Care Act, or ACA, into law. And 7 days later, he signed the Health Care and Education Affordability Act of 2010, which made some changes to the law. So together, those two laws are commonly referred to as the Affordable Care Act, or as we're going to call it, the ACA. The ACA will result in major changes in the way our country's health insurance and healthcare systems work, as well as provide affordable health insurance to an estimated 32 million more people. We know that today there are an estimated 48 million non-elderly uninsured Americans. The ACA seeks to address the gaps in our private and public insurance systems by reforming the health insurance marketplace, by adding a new eligibility category to Medicaid that has the potential of covering 17 million uninsured Americans, and by providing access to subsidized private health insurance coverage for low-income individuals through health insurance marketplaces or exchanges. So we're going to review each of these three areas, starting with insurance market reforms. So if you remember way back during the debate over the passage of the ACA, you may remember stories of families that have been let down by the private health insurance system. such as parents unable to buy health insurance coverage for their infant born with a serious medical condition, or a woman forced to stop chemotherapy for months while fighting her insurance company's claim that her cancer was a pre-existing condition. Well, a major goal of the ACA is to put consumers back in charge of their health coverage and care. The ACA provides new regulations that change the rules that the insurance industry has to play by. This section will review some of these new rules that have been put into place by the ACA. Before the ACA, millions of Americans living with costly medical conditions were at risk of having their health insurance coverage disappear when their costs reach a lifetime limit set by their insurance company. Because of the ACA, now no insurance plan issued or renewed after September 23, 2010 can use such a lifetime limit. Even more binding than lifetime limits are annual or yearly dollar limits on what an insurance company will pay for health care. The ACA phases out the use of annual limits over the next 2 years for most health plans before banning such annual limits entirely in 2014. Also effective January 1, 2014, in the individual and small group health insurance markets, the ACA eliminates the ability of insurance companies to charge higher rates due to gender. Before the ACA, insurance companies were able to retroactively cancel someone's insurance policy when they became sick, or if they or their employer made an unintentional mistake on their paperwork. But now, under the ACA, insurers are not allowed to rescind coverage except in cases involving fraud or an intentional misrepresentation of material fact. The next rule that was changed by the ACA is pre-existing conditions. So the ACA implements strong reforms that prohibit insurance companies from refusing to sell coverage or renew policies because of an individual's pre-existing condition. That is, a health problem like diabetes or high blood pressure, for example, that developed before the person applied to join the health insurance plan. So now, because of the ACA, health insurers cannot limit or deny benefits or deny coverage for a child younger than 19 simply because that child has a pre-existing condition. And starting in 2014, these protections will be extended to adults too. So what happens if today you're an adult with a pre-existing condition and have been unable to find insurance for 6 months or more? Well, the ACA gave $5 billion of federal funding to the states to create temporary high-risk pools to provide health insurance for people who have pre-existing conditions and who have been uninsured for at least 6 months. This new temporary high-risk pool is a bridge until 2014 when the ACA will require insurers to cover adults with pre-existing conditions. So in Illinois, this temporary high-risk pool is called IPXP, and you must be a U.S. citizen, national, or legal resident in order to be eligible. For more information, see the website listed on this slide. The ACA also helps small businesses and small nonprofit organizations afford the cost of providing health insurance to their employees. If you have fewer than 25 employees and provide health insurance, you may qualify for a tax credit of up to 35% and up to 25% for nonprofits to offset that cost of insurance. This credit actually increases in 2014 to 50% and to 35% for nonprofit organizations. So this tax credit helps make the cost of providing insurance much lower. For more information, please see IRS.gov. The ACA also has a dependent coverage provision that allows young adults up to age 26 whose parents have health insurance with a dependent coverage provision to be able to stay or add on to that coverage. So here's how it works. you have to be younger than 26 years old, and your parent has to have a health insurance plan that provides for dependent coverage or coverage for the children in the family. Then you can select and purchase the dependent coverage option. In fact, over 3 million additional young adults have insurance coverage as of December of 2011 due just to this single ACA provision. The ACA also has a new rule that requires insurance companies to spend your premium dollars primarily on health care. The percentage of your premium dollars that an insurance company spends on providing you with health care as opposed to what it spends on administrative, overhead, and marketing costs is known as the medical loss ratio, or MLR. So the ACA limits how much of your premium dollar your insurance company can spend on those things other than providing health care and improving its quality. And if your insurance company exceeds that limit, it must provide a rebate of the portion of premium dollars that exceeded that limit. So the ACA requires insurers selling policies to individuals or small groups to spend at least 80% of premiums on direct medical care and efforts to improve the quality of care. And insurers selling to large groups must spend 85% of premiums on health care and quality improvement. Insurers were required to make the first round of rebate checks to consumers in 2012. So you may have received a check in the mail or a reduction in your premiums. Also under the ACA, people joining a new private health insurance plan must be able to receive recommended preventive services with no out-of-pocket costs, such as copays or deductibles, when using an in-network provider. This slide lists the preventive services that do not have any cost sharing and thus are essentially free. This next slide lists the women's preventive services that, as of August 1st of this year, are covered by new private health insurance plans, again without cost sharing. I'm going to highlight a few. So there is no cost sharing for Food and Drug Administration approved contraceptive methods, which will result in improved maternal health and better birth outcomes. And there's no cost sharing for gestational diabetes screening for women 24 to 28 weeks pregnant and those at high risk of developing gestational diabetes. This will help improve the health of mothers and babies because women who have gestational diabetes have an increased risk of developing type 2 diabetes in the future. And also included in these no cost sharing preventive services are well women visits to obtain the recommended preventive services and any additional visits to their doctor if women and their providers determine that they're necessary. So now that we've talked about some of the ways that the rules have changed for the insurance companies because of the ACA, I'm going to turn it over to Kathy, who's going to talk about the new health insurance exchange marketplace. Kathy?
Thanks, Andrea. The health insurance exchanges are a major cornerstone of the Affordable Care Act. Individuals and small businesses too often pay higher health insurance rates because they lack collective purchasing power and the ability to pool and share risk, which is an advantage that larger companies have. The ACA helps even the playing field for individuals and small businesses by providing them with competitive, consumer-centered health insurance marketplaces, which are also called exchanges, in order to compare and buy insurance, thereby increasing their control and choice. So starting in 2014, states are required to have in operation their health insurance exchange, which will serve as a one-stop shop that will allow individuals and small businesses to better understand their options for private insurance coverage. It will also serve as a place where individuals will see if they are eligible for public coverage programs or tax credits or subsidies to help them afford private insurance. Exchanges are required to provide health insurance information in a clear, user-friendly format that allows consumers to understand plan terms and compare benefits and services across these different plans. In the exchanges, users will have access to a wide range of customer assistance tools, including information about prices, quality, and physician and hospital networks. the plans that are offered in the exchange will be required to provide at least a basic level of comprehensive benefits. So how will all work? Well, the applicant would input their preference for the type of insurance plan, and the exchange will provide the different plans and benefits that meet their criteria. Household income, family size, and things like citizenship information or residency status will be verified through data matching with state and federal databases. Plans that are offered on the exchange must be certified as what's referred to as qualified health plans, meaning that they must meet minimum requirements such as having enough providers to cover their patients, contracts with essential community providers, and performance on quality measures. The health insurance exchange will help keep prices low by increasing competition among private insurance plans through the improved comparative shopping and by better extending customers and small businesses the same purchasing power in the exchanges that large businesses already have today. The launch of the exchange, in combination with other private health insurance reforms, will result in more people gaining access to health insurance and other system simplifications, which are projected to reduce average health insurance premiums by 7 to 10%, according to the Congressional Budget Office. In Illinois, it's expected that by 2020, 1.4 million Illinois residents are projected to get coverage from the exchange. The ACA helps ensure that health insurance covers medically necessary services for most people by requiring health plans offered in the individual and small group markets that exist both inside and outside the exchange offer a comprehensive package of items and services, which are also known as essential health benefits. Essential health benefits must include items and services within at least the 10 categories that are listed on the slide. So starting in 2014, insurance policies must cover these benefits in order to be certified as a qualified health plan, which will allow them to participate on the exchange. Additionally, Medicaid for those who are newly eligible for coverage in 2014 must also cover these categories of service. This August, Governor Quinn's office convened a work group of representatives from a number of state agencies to develop recommendations about Illinois' choice for a benchmark plan that includes the essential health benefits. The next month, the work group recommended that the Blue Cross, Blue Shield, Blue Advantage small group plan, as well as all kids to serve as the benchmark plan for children's dental, and the federal pediatric vision plan as the benchmark for children's vision. The Essential Health Benefits Benchmark Plan will be in effect in Illinois for plan years 2014 and 2015. This benchmark plan selection serves as the minimum standard of coverage that all new plans in Illinois must meet starting in 2014. While the covered services do not have to be exactly the same as what's in the Blue Cross plan, the actuarial value or richness of the plan must be equal to or exceed the benchmark. The federal government has indicated that they will provide future guidance on changes in the benchmark plan for plan years 2016 and beyond. And the governor's work group plans to review the impact of the benchmark plan over the first 2 years and accept feedback from the public on this plan. The work group stated that they hope to engage stakeholders and ensure that the minimum coverage offered in Illinois meets the needs of all residents. The ACA sets aside federal funding for families with household incomes between 100 to 400% of the poverty level to provide financial assistance in paying for insurance premiums. So if a lower income family makes too much to qualify for Medicaid but still cannot afford private insurance on their own, there is financial help from the federal government to help with the cost of private insurance. Applicants will learn if they qualify for this financial help when they apply for insurance on the exchange. Those on the higher end of this income scale would receive fewer subsidies, and those on the lower end would receive more. In Illinois, it's projected that 73% of people who enroll on the exchange will be eligible for some form of federal assistance. This slide shows the income eligibility guidelines for the financial help. For example, a single parent with 2 kids would need a household income of less than $76,000 in order to qualify for the financial help to use to purchase health insurance. Additionally, those with incomes between 100 and 250% of the poverty level may also be eligible for cost-sharing subsidies that will help them pay for out-of-pocket costs such as deductibles and copays. And while the formula to figure out how much an individual or family would be eligible for in tax credits is rather complicated, here's my shot at trying to explain this. So what you would do is start with the individual or family's annual income. This will determine the maximum amount the individual or family will pay for their health insurance premium. The lower on the income scale someone is, the less money they will be expected to pay. Next, you would identify the second lowest cost silver tier plan that is available in that person's zip code. This plan would serve as the reference plan, and the tax credit will be set using this plan so that the individual or family does not have to pay over a certain percentage of their income for the cost of this plan. However, the family is welcome to choose from a lower cost plan in the bronze category or a higher cost plan in the gold or premium category, but the tax credit amount will still be based on the second lowest cost silver tier plan. So this slide shows some examples of what the maximum monthly premiums would be capped at. So for example, a family of 4 would be eligible for cost-sharing subsidies as well if they had income below 250% of the poverty level. So the first example here shows that the family of 4 with an annual income of around $44,000, which is at 200% of the poverty level, if they were to look at a silver tier plan in their area, the maximum monthly premium would be capped at $232 per month, and then the annual premiums could be capped at an amount of $2,778 a month. Obviously, this would depend on how much the silver tier plan would cost in that person's area, and these are based on kind of average costs that are estimated to be in place in 2014 when the exchanges are up and running. So this is just an example. Of course, there could be variances in this depending on where someone lives. The ACA also requires the exchange to establish navigators, and navigators are intended to help individuals or small businesses that are eligible to purchase insurance through the exchange. Navigators will also help guide small businesses that are eligible for the exchange through the insurance purchasing process and will help people who are eligible for Medicaid with the enrollment process. Navigators will also assist people in learning about insurance options and about any tax credits that someone may be eligible for, as well as help with enrollment into a plan. They will also be responsible to refer those who have problems with their plan or other elements of the exchange to an agency that can help assist with that problem. Navigators will be required to provide information in a way that is fair and impartial in order to help consumers choose the insurance plan that best fits their needs. Navigators are required to serve all facets of a diverse population adequately, including those with low income, single parents, homeless, those with HIV/AIDS or other chronic health conditions, those who are currently or formerly incarcerated, and immigrants. The navigator role will be filled by people from a wide array of organizations, such as community and consumer-focused nonprofit groups, trade, industry, and professional associations, chambers of commerce, unions, partners of the Small Business Administration, and licensed insurance agents and brokers. States are required to operate a health insurance exchange starting in 2014, as mentioned in the earlier slide. If a state is unable or unwilling to do so, the federal government will run the exchange for them, or states can choose to partner with the federal government to run the exchange. Illinois has chosen to partner with the federal government to run our exchange in 2014 and has announced an intent to run our own state-based exchange starting in 2015. Illinois must submit an exchange blueprint to the federal government by November 16th of 2012, which will outline which exchange functions Illinois would like to operate, which could include plan certification for participation in the exchange and portions of the Navigator program. The Illinois General Assembly will need to pass legislation to authorize a state-based exchange, so IMCHC, the Shriver Center, and ICIRR will be sure to be at the table for these discussions. Again, starting in 2014, the individual mandate or responsibility provisions require all U.S. citizens and lawfully residing immigrants to have health insurance coverage. This coverage can be in the form of public coverage, in the form of Medicaid or Medicare, or private insurance that's through an employer or purchased inside or outside of the exchange. This provision is critical for minimizing what's referred to as the hidden tax that many people with health insurance pay that's used to cover the cost of care for the uninsured. Right now, the average American family with insurance pays over $1,000 a year in higher premiums just to cover the cost of care for the uninsured. Since everyone will be required to have health insurance, not just the sick and the old, but also the young and healthy, there will be a broad pool of people with health insurance to spread the risk. This will help balance out costs and keep them under control for everybody. The Congressional Budget Office estimates that about 4 million, or just 1.2% of the total population, will actually pay a penalty in 2016 for not having health insurance. The other 98.8% who already have coverage or would get covered under the ACA would be exempt from the mandate or would owe the penalty but try to evade it. Certain individuals will be exempt from the mandate, including undocumented immigrants, Native Americans, and individuals whose cost of insurance exceeds a certain percentage of their income. So in this section, I'm going to cover changes to Medicaid that will have a dramatic impact on how low-income Illinois residents will access health coverage. But first, let's review current law. Under current federal law, in order to qualify for Medicaid, a person must meet financial eligibility and also belong to one of the groups that are categorically eligible. These categorically eligible groups include pregnant women, children, some low-income parents, most elderly, and persons with disability who receive Supplemental Security Income, or SSI. In addition to these requirements, a person may also be required to meet citizenship or residency requirements. In Illinois, the major programs funded by Medicaid include the following. So many of you are probably familiar with the All Kids program, which is for children living in Illinois with household income below 300%. There are no immigration requirements for all kids, but children must be a resident of Illinois. And the Family Care program is for parents and relative caregivers living with children under the age of 19 years. Participants must have family income below 133%, and they must also be either a U.S. citizen or legal permanent resident with at least 5 years of residency. Moms and Babies is a program specifically for pregnant women and infants up to 1 year of age with family income of 200% of the poverty level or less. There are no immigration requirements for this program, and it's also worth noting that a pregnant woman counts as a family of 2. We've provided an overview of these programs because we know that there are still individuals currently eligible but not yet enrolled in these programs. We hope that you will be able to share this information with your community to help connect eligible persons with coverage right now and not wait until 2014. And you can visit www.allkids.com or call the toll-free number that's listed on this slide for more information. So given what I just presented about how Medicaid works now in Illinois, you can see that there are many individuals who aren't able to currently qualify for Medicaid because they don't fit into one of the eligible categories. But the ACA helps fill this gap by creating a new eligibility category for these individuals, many of whom are referred to as childless adults because they don't have children in the household. Beginning in 2014, the ACA extends Medicaid coverage to all individuals between ages 19 and 64 with incomes up to 138% of the federal poverty level, or $14,800 a year for an individual, and or $30,600 a year for a family of 4. For example, an uninsured 55-year-old woman with no children who is a server in a restaurant that does not offer insurance could qualify for Medicaid under this new coverage group if she earns less than $14,856 over the course of a year. The same goes for a college graduate who is working a minimum wage job after graduation. The ACA does not change any of the rules regarding immigrants' eligibility for Medicaid, which only allows for U.S. citizens and certain lawfully residing immigrants, including legal permanent residents with at least 5 years of U.S. residency, refugees, and asylees to qualify. The cost of those who are newly eligible in 2014 will be covered at 100% by the federal government through 2016, and this year will gradually decline to 90% in 2020, but will never go below this amount, making the new Medicaid coverage a great financial deal for states to implement. This chart shows the income eligibility for this new group with household incomes, and this slide you'll note mentions that this is at 133% of the poverty level. I did mention 138% in the previous slide. Oftentimes these numbers are used interchangeably, and the reason is because 138% takes into account an automatic 5% income disregard that will be applied to those who are newly eligible in Medicaid. So if you hear 133 or 138, just know that it means the same thing. Those numbers are very close. But this gives you an idea of what that looks like for the different family sizes. It's estimated that over 520,000 people will be newly eligible for Medicaid in 2014, and this slide shows the breakdown by racial and ethnic groups as well as parental status. And as mentioned earlier, those who are newly eligible for Medicaid in 2014 will receive covered services that are in line with the benchmark benefits that include all of the essential health benefits, which are again listed on this slide. The ACA encourages the use of methods that reduce burdensome requirements that have often made it difficult for individuals to gain access to coverage or renew their coverage. Some of these simplifications include a new income standard, which is oftentimes referred to as Modified Adjusted Gross Income, or MAGI, that will be used to determine eligibility for all subsidized health programs, including Medicaid. There will no longer be an asset test for those who are newly eligible for Medicaid in 2014. And there will also be a no wrong door approach, meaning that there will be a single application form for all health programs, that applications can be made online, in person, by mail, or phone. Applicants will be screened and enrolled in appropriate coverage options regardless of their entry point, and no unnecessary information will be required or requested from the applicant. The ACA also sets forward expectations to have a single web portal for enrollment with real-time eligibility determinations using data that is electronic. This will allow for the use of paperless verifications by cross-matching information in other state and federal databases, which can allow for a more efficient use of administrative resources. To help make states make necessary systems upgrades, the federal government is providing significant financial support for these IT systems, which Illinois is taking advantage of. State verification processes will include verifying selected elements of eligibility, allowing individuals to address inconsistencies and also allowing people to correct information, and using the electronic data to allow for a more efficient use of administrative resources, as mentioned earlier. Through the exchange, there will be a coordinated eligibility determination system that allows individuals to apply for Medicaid online, in person, by mail, or by phone through this one streamlined application. And as you might guess, many of the people who will be newly eligible for Medicaid are already in contact with state human services programs. Federal SNAP, which is also referred to as food stamps, income eligibility is 130% of the poverty level, which means that most SNAP households have at least one member, who's often a child, who's eligible for Medicaid now. And the overlap between SNAP and Medicaid eligibility will be even greater in 2014 when new Medicaid will have coverage for parents and childless adults with incomes up to 138% of poverty. In fact, many low-income parents and adults without children who will gain Medicaid eligibility in 2014 are currently eligible for and receiving SNAP benefits. And because the state already knows who is receiving these benefits, streamlining the enrollment policies and practice so that people on SNAP can be automatically or more expeditiously enrolled in Medicaid will be an important strategy for responding to the pending enrollment surge and ongoing workload. Additionally, SNAP has a very high participation rate among those eligible for the program, which is that over 80% among families with children and over 60% among the non-elderly childless adults. So using SNAP participation as a way to connect eligible parents and other adults to the exchange and therefore to Medicaid will be an important outreach tool. And now I'm going to turn it over to Andrea, who's going to talk about the Supreme Court decision and some pending policy issues.
As you may know, after President Obama signed the ACA into law in March of 2010, over 24 lawsuits were filed alleging that the ACA was unconstitutional. This past June, the United States Supreme Court decided one of those cases, and in doing so, essentially upheld the entire ACA as constitutional, including the new eligibility category for Medicaid that Kathy just discussed. However, the Supreme Court in its decision did make one important change to how this new Medicaid eligibility category can be enforced, and we want to take a minute to discuss it. The Supreme Court held that the federal government is not allowed to penalize states that choose not to participate in the new Medicaid eligibility category by taking away their existing Medicaid funding. So what does that mean in practical terms? Well, first, the court ruled that the new Medicaid eligibility category is still valid, but now this category is effectively a state option. That means that each state will have to decide whether to implement the new eligibility category. There are many questions about how this new eligibility category will be administered. We're still waiting for final regulatory guidance from the federal government on a lot of these questions. However, we do know that adopting this new Medicaid eligibility category makes a lot of sense for the state. In Illinois, Governor Quinn has publicly stated that Illinois will add the new eligibility category to its Medicaid program in 2014. However, it will likely take the support of Illinois legislators this veto session to actually make this happen. Legislators and other state decision makers need to understand why adding this new eligibility category in Illinois' Medicaid program is such a good deal for our state, for any state really. This slide lists some of the reasons why it is such a good deal for our state. First, covering this newly eligible population will require minimal state investment to reap overwhelming benefits for Illinois. The federal government, as Kathy said, will pay the entire cost of this new group for the first 3 years, and after that, Illinois will be responsible to fund no more than 10% of the cost. Second, covering this new group is going to create jobs and generate revenue for our state. It will also help stabilize the state budget, which is critically dependent on federal Medicaid funding, which is the largest source of federal revenue to the state. Covering newly eligible people will save taxpayers money. If Illinois does not cover this newly eligible population, insured Illinoisans will continue paying $1,000 annually as an increase in their premiums to cover the cost of the uncompensated care. Covering newly eligible people will pay doctors and hospitals for the work that they do. As you all know, Medicaid funding supports safety net institutions that provide health care to low-income people and uninsured people. Covering this new group is also the linchpin for bigger reforms that will deliver both better health outcomes and lower costs. Covering this new group will help hundreds of thousands of low-income people develop a relationship with a primary care provider, often for the first time. It will pull down federal Medicaid dollars to pay for behavioral and mental health services for Medicaid enrollees, a majority of which are currently funded exclusively by state and local funds. An estimated 43,000 Illinois veterans would gain Medicaid coverage in this newly eligible group. And as I said earlier, covering newly eligible people is still required by federal law under the ACA. The Supreme Court reinforced this fact in its decision. The ACA counts on Medicaid eligibility reform to cover, as we said at the beginning, 17 million of the 37 million people expected to gain coverage under the ACA. 2/3 of these people expected to become eligible for Medicaid as a result of the ACA have incomes below 100% of the federal poverty level, which, as we just learned from Kathy, would be too low to qualify for exchange subsidies. So there is this coverage gap if we did not have this new Medicaid eligibility category. In Illinois, an estimated 430,000 Illinoisans are under 100% of the federal poverty level, and they would be without coverage if this new eligibility category was not implemented. The remaining third, who are to become newly eligible for Medicaid, will have income between 100 and 138% of the federal poverty level and could qualify for those premium subsidies through the exchanges. But the subsidies were not designed for them, and many of those people would still find the subsidies insufficient to afford private insurance. So it's, again, crucial that we all work together to ensure that Illinois actually adopts the ACA's new Medicaid eligibility category. So now that we have an understanding of the Affordable Care Act, let's see how certain ACA provisions that we've just talked about will affect immigrants. So many of the 10 million non-citizens in the United States are expected to gain health insurance coverage through the ACA. Those who are considered lawfully present will be able to take advantage of many of the ACA provisions. In July 2012, the U.S. Department of Health and Human Services defined lawfully present when they were determining who would be eligible for the ACA's high-risk pools. The definition of lawfully present generally tracks the definition used in Medicaid to provide affordable coverage to low-income children and pregnant women who are lawfully residing in the United States. Lawfully present individuals include not only those classified as qualified immigrants, but several other categories of non-U.S. citizens who have permission to live and or work in the United States. The immigration categories listed on this slide are considered lawfully present for the ACA eligibility purposes. So now that you see who is considered lawfully present, let's apply that to the ACA provisions. Starting in 2014, those who are lawfully present who do not get coverage through their jobs will be able to purchase health coverage through the new health insurance marketplace or exchange that Kathy spoke about. Since many lawfully present immigrants are in low-paying jobs, they may also qualify for Medicaid, although they are not eligible for that coverage until they've been in the country for at least 5 years. As we've already said, the ACA adds a new Medicaid eligibility category to include people earning up to 133% of the federal poverty level. An estimated 57% of uninsured non-citizens meet that income requirement. Lawfully present immigrants earning more than the Medicaid limit could qualify for the federal subsidy aimed at helping people earning that 100 to 400% of the poverty level purchase private health insurance coverage through the exchange. Immigrants who are lawfully present must buy health insurance under the individual mandate unless it's unaffordable or they're exempt. Undocumented immigrants. The estimated 11 million immigrants living in the United States who are undocumented and are not eligible for federal Medicaid, nor can they qualify for federal subsidies to purchase private health insurance on the exchange. Undocumented immigrants are also barred from using their own money to purchase insurance through the exchanges. According to the Robert Wood Johnson Foundation, almost a quarter of those who will remain uninsured in 2016 would be undocumented immigrants. And in Illinois, it's estimated that in 2014, that will be 139,000 people of all, or 18.1% of all non-elderly uninsured persons are going to have that insurance status of being uninsured because they're undocumented immigrants. Undocumented immigrants are not subject to the ACA's mandate that they carry insurance. Undocumented people will remain eligible for health programs that are available regardless of immigration status. So hospitals must still provide emergency care regardless of insurance or immigration status. Community health centers will continue to provide non-emergency health care regardless of immigration status. Recognizing that more health centers would be needed to help care for both the newly insured and the uninsured, Congress did allocate $11 billion over the next 5 years for community health centers. Undocumented people are eligible to be covered in group health insurance as a dependent, and insurance companies may offer insurance outside of the state exchanges to undocumented individuals, although it's unclear how affordable or comprehensive those plans will be. Also, undocumented immigrants could gain health insurance through cooperative health insurance programs that are also offered outside of the exchange. U.S. citizen children of undocumented parents should have the same access to health insurance and health services as other children. So they will still be eligible for Medicaid, eligible for tax credits to make health insurance affordable. They should be eligible to buy health insurance in the exchange for using their own application. Now I'm going to turn it over to Kathy to talk about some advocacy opportunities.
Thanks, Andrea. So when it comes to the new eligibility category for Medicaid, the next 6 to 8 months are really critical. States must include these new Medicaid groups in their budget for fiscal year 2014, which for Illinois will start July 1st of 2013. ICIRR members are close to the new eligibles, and your clients are the real people whose stories can cut through the partisanship and touch hearts. We really need to mobilize and present the facts, and the facts really are on our side. We also need to work to preserve the Medicaid eligibility for undocumented children that currently exists in all kids that comes under attack every year, and make sure that we also protect existing Medicaid coverage. As many of you know, there was Medicaid reform legislation last year that really devastated the Medicaid program. We need to make sure that we prevent any additional cuts to the program and are especially vigilant when it comes to coverage for undocumented children. When it comes to advocacy opportunities, there's lots of upcoming opportunities. So as you know, the elections are coming up. So elections on November 6th, while healthcare is not necessarily on the ballot, you can look and see which legislators support the issues of healthcare access and use that as a way to determine who's going to get your vote. We also want to encourage you to get involved with veto session here in Illinois, which the dates are also listed on this slide. And we want you to talk to your legislators about the things that you've heard about in this presentation today, as well as all of the other health concerns that you have for your community. The HFS website is another good place for your organization to get connected, and that website is on the slide as well. There's a Medicaid Advisory Committee that meets every other month that is a public opportunity for individuals who want to provide input to Healthcare and Family Services about how the Medicaid program is working or not working at these meetings. The Healthcare Reform Implementation Council is a council that's been organized by the governor that has made decisions on and recommendations on Navigators as well as on essential health benefits. And we expect that as implementation picks up, this council will continue to meet on a regular basis. We also encourage you to subscribe to the Illinois Health Matters website, and there will be more information about that in the next slide. But our organizations that are participating in this webinar today all contribute to that website, and it's a great place to share and get information on health reform implementation. So other places that you can get information about healthcare reform and healthcare services is the first one that we want to mention is healthcare.gov. This is the federal government's website. It's actually a great website that you can use as a resource. It's very user-friendly, and it provides a lot of really great information about the Affordable Care Act. On the next slide is information about Illinois Health Matters, which was mentioned earlier. It's really a one-stop shop for all sorts of individuals, including consumers, providers, policymakers, as well as members of the media. That includes blog entries, fact sheets, reports, and videos. And so we encourage you to visit this website and sign up if you're not already participating on this website or subscribe to their emails. And now I'm going to turn it back over to Livia.
Thank you, Kathy and Andrea. We'll now answer any questions you might have. Again, you can ask questions by typing into the chat feature and sending them to us. After we answer the questions, we'll go ahead and take some questions if people want to post them. As we are going through the questions, I just want to remind people that after the webinar, there will be a short survey that if you could just take a few moments to fill out, we would greatly appreciate it. Also, all registrants to this webinar will receive a link to a recording of the webinar that will contain a recording of the webinar as well as the PowerPoint slides from the webinar.
So a question has been posed to us that is, could you please repeat the info on the new Medicaid eligibility categories already available now? Let me answer this in two parts. So there are individuals who are currently eligible for Medicaid, and in 2014, there's going to be a new category that will be eligible. The individuals that are eligible now must meet both income guidelines and also what's referred to as categorical eligibility, meaning that they fit into a category such as being a child 18 and younger, being a parent with a child, being a parent of a child 18 or younger and living with them, being somebody who meets the Social Security definition of being disabled. In 2014, there will no longer be those categorical eligibilities. So as long as you meet the income requirement, which is having income at 138% or below, as well as meeting citizenship or residency requirements, those individuals will be newly eligible for Medicaid. So those categories are effectively going away, and as long as you meet the immigration and income requirements, those individuals will be newly eligible for Medicaid. There's another question that's just asking for clarification. The question or statement is, I'm unclear if an undocumented mom and baby qualify for ACA. So right now, there is a program that's available in Illinois called Moms and Babies that is available to pregnant women and infants up to the age of 1 that does not have immigration requirements for that pregnant woman. So if a pregnant woman has income at 200% of the poverty level or below, she can qualify for Moms and Babies as long as she's a resident of Illinois and, again, meets that income requirement. There are no immigration requirements, so she can be a citizen, a permanent resident, or undocumented and qualify for that. The All Kids program also allows for children with incomes up to 300% of the poverty level to qualify for health insurance coverage. And again, that's regardless of immigration status. So children who are citizens, permanent residents, or undocumented, as long as they live in Illinois and as long as they meet that income requirement, can qualify for the All Kids program.
We have a few more minutes for any other last-minute questions.
This is Kathy, and I just want to reiterate that, we gave you a lot of information in today's presentation. So if you do have any follow-up questions, please don't hesitate to contact any of us on the presentation today, especially if you're reviewing the slides later and questions come up that maybe you didn't hear about, or that you're reading the slides and something's unclear. We certainly want to be available to answer your questions and also offer opportunities for us to present either in person or do a briefing by phone to also, provide more in-depth detail about any of these areas that we talked about today or other pieces of the Affordable Care Act and health reform implementation that maybe weren't addressed in enough detail today.
The immigrants that are eligible. Everybody is undocumented.
So we have a question regarding reviewing the groups of immigrants who are eligible for the ACA, and that would be the lawfully present individuals. Michelle, can you? Okay, it's slide 32. So we're going to go ahead and put that slide back up again so you can see. These are the individuals who the ACA deems as lawfully present, and they will be able to buy health insurance on the exchange. They will be able to qualify for the subsidies on the exchange. They will also be subject to the mandate.
So there's another question that's been posed, which is how will tax returns play a role in determining the income levels and eligibility? So this is a good question. I'm going to try to answer this, and Andrea and Livia, you should jump in as well. So I think that the actual process is still being worked out, but the IRS will have a role in determining whether somebody meets the individual mandate or personal responsibility provision. And this is the provision that says that if you can afford insurance, you have it, so that everybody has insurance. And remember that both public and private forms of insurance meets the requirement for this mandate. So in terms of the role that tax returns will play, the way that it's worked in Massachusetts, to my understanding, which obviously much of the ACA has been patterned off of what's already been done in Massachusetts over the past several years, is that they use the